So the spleen is an intraperitoneal organ. It measures 7 to 13 centimeters and lies in the left lower thorax. It is protected by the 9th, 10th and 11th ribs. In a healthy individual, it is not palpable below the costal margin. There are two surfaces of spleen. One is the diaphragmatic surface and the visceral surface. The diaphragmatic surface is roofed by the diaphragm, separating it from the left pleura. And now the visceral surface, it is in close proximity to the greater curvature of the stomach, the splenic flexure of the colon, the apex of the left kidney and the tail of the pancreas, which is in close proximity to the hilum of the spleen. Now also the fracture of the left lower rib, you should assume that whenever there is a fracture of the left lower rib, there should be a splenic injury, which is commonly seen. It is suspended in position partly by multiple peritoneal reflections, which are commonly misreferred to as ligaments. Now at the diaphragmatic surface, there is a splenophrenic ligament. At the visceral surface, there is a gastrosplenic that connects the spleen to the stomach, splenorenal, spleen to the left kidney, and splenocolic. In patients with portal hypertension, splenophrenic and the splenocolic ligaments become vascular, which is otherwise avascular. The gastrosplenic ligament carries the short gastric superiorly and the left gastroepiploic inferiorly. The splenorenal ligament houses the splenic vessels as well as the tail of the pancreas. The important note is that the tail of the pancreas is within 1 centimeter of the splenic hilum, and therefore it is important that when you are doing a splenectomy, the vessels, the splenic vessels should be ligated within 1 centimeter of the splenic hilum to avoid injury of the tail of the pancreas. Now the spleen enlarges usually medially because downward displacement is prevented by the phreniocolic ligament. This is the anatomy of the spleen. You can see the stomach, greater curvature of the stomach, the left kidney, above there is a diaphragm, the 9th rib, anteriorly you can see the splenorenal ligament, the tail of the pancreas which you can see there below, and the transverse colon. Now over here in the first photo is the anterior peritoneal attachments and below is the posterior peritoneal attachments. It shows the inferior diaphragmatic peritoneum, origin of the splenorenal ligament, the phrenicosplenic ligament, splenocolic ligament and the phrenicocolic ligament which is below. And the B picture is the anterior attachments which shows the anterior border of the spleen, the gastrosplenic ligament that is seen going anteriorly to the greater curvature of the stomach. Let's come to the blood supply. The splenic artery is a branch of the celiac trunk. It travels along the superior and behind the pancreas to supply the spleen. Now splenic artery has two types of distribution which is important in surgery. You've read the rest of the part in anatomy, I'm assuming, but the rest of the part is important in surgery. There are two distributions, that is, one is the magistral type and the distributed type. So magistral, basically in magistral there are two polar arteries. It divides into two polar, upper and lower polar. In distributed, there are multiple artery branches that divides just away from the hilum. Now why is this important? To understand what kind of variation of the splenic artery? It is important when you are doing splenectomy, it is important that you ligate the splenic arteries, otherwise it will lead to bleeding. You don't want that. Splenic vein is formed by the union of several splenic veins and the left gastroepiploic vein. Now the splenic vein joins the superior mesenteric vein to form the portal vein. Now I'll come to the functions of the spleen. In short, I will be telling you the basic function is filtration, that is pitting and culling. Removal of non-deformable intracellular substances is pitting. Culling is removal of aged or abnormal red cells. Coming to immunity, you know that it is important in synthesis of IgM, lymphocytes, tuftin, properdin, opsonin and interferons. Hematopoietic, as you must have read, that it is a major organ for formation of blood cells during the fetal life, the first 3 to 4 months of the fetal life. Also it acts as a reservoir for platelets. Now let's come to the next important topic of the day, that is splenic injury. Now splenic injury commonly follows either a road traffic accident or a blunt abdominal injury. It is often associated with fracture of the left lower ribs, and because it is in close proximity to certain organs, you should always look out for injury to the left lobe of the liver, tail of the pancreas, left kidney, and also sometimes the colon, splenic flexure of the colon. Now, splenic injury is more common in case of enlarged spleen because it becomes more palpable and hence it is more prone to injury. Also, spontaneous rupture of the spleen is seen in certain cases such as malaria and infectious mononucleosis. As an MCQ for your future exams, spleen is the most common solid organ injured in blunt abdominal trauma. Now, we'll come to the presentation of splenic injury. There is rapid development of shock and early death may occur if not intervened promptly. Now, emergency splenectomy is mandate in severe cases so as to prevent bleeding. Now, what will be the symptoms? It shows symptoms of shock, that is pallor, tachycardia, low BP and restlessness. Tenderness and abdominal rigidity is seen in the upper abdomen. Now, there are several signs in case of splenic injury. These signs are important. One is the Kehr sign. There is pain in the left shoulder. Then balances sign, left-sided abdominal dullness that does not shift. Say-Gasser's sign, that is tender point between the left sternocleidomastoid and the scalenus medius muscle, and the latent period of bandit. So what happens is initially when there is bleeding, a clot is formed. The clot goes and gets dislodged, lodges itself in the splenic trauma site, which prevents further bleeding, and only soon that clot gets dislodged and leads to more bleeding. So this time period between the clot lodgement and dislodgement is known as the latent period of bandit. Yes. Say-Gasser's sign is that there is a tender point in between sternocleidomastoid and scalenus medius. So because the diaphragm, if you know that phrenic nerve has origin from C3, C4, C5, right? So also if you know that when we do laparoscopy, if gas remains inside the abdomen, there is irritation in the left shoulder. This is because phrenic nerve gets irritated. Similarly, because of blood, there is blood in the left upper abdomen which irritates the diaphragm, and hence there is tenderness here, like there is a tenderness point over here which is seen in the shoulder because of the phrenic nerve. When you touch the point in between there, you will find tenderness over there. But that is not a definitive sign for you to diagnose. There are a lot of other signs that you will be seeing to diagnose splenic injury. This is just a said sign that you are seeing in splenic injury. This sign is not going to help you diagnose splenic injury. For diagnosing splenic injury, there will be a lot of things. Patient will have history of RTA. Then apart from that, patient will show signs of shock. These signs are simultaneously seen along with those signs. This is just a, how do I put it, just, you know, you have to just mug up this and it will help you in MCQs. And anyways, let's come to the investigations. Now, for any trauma patient, that patient comes with, let's say, road traffic accident and he's showing signs of abdominal injury. The first step that you have to do in trauma is known as the FAST, focused assessment with sonography in trauma. So, in any case, you will read upon it later on, but ultrasound abdomen is the investigation of choice. It gives you quicker results. It will tell you if there is a splenic injury or not. Now, apart from this, you have to also do hemoglobin. So, why hemoglobin is important? Can someone tell me? 6-hourly hemoglobin is done. Normally, in cases of practically, we go for a 6-hourly hemoglobin. Can you tell me why? Blood loss is there, right? To see whether there is, if there is active blood loss or the blood loss has stopped. So, why do we do 6-hourly? We do 6-hourly because if supposedly hemoglobin is 10 right now and it is falling in the next 6 hours, then you know that there is an active blood loss. If it is less and it has stopped, that you know that there is not an active, there was a blood loss, but it has stopped. So that is why continuous 6-hourly monitor is important in case of splenic rupture and liver rupture. Both in liver trauma and splenic trauma, we do 6-hourly hemoglobin. Apart from that, you do blood grouping, cross matching, so that you can prepare for packets of blood if it is required. CT scan will show the type of splenic injury and its class. There is CT scoring, which will say that whether you can go for a non-operative management or an operative management. Now, these are just the X-ray findings. Obliteration of splenic, that is normally seen on a normal X-ray, but in case of splenic injury, these things are seen. Obliteration of splenic outline, obliteration of psoas shadow, absence of or indentation of the fundic shadow, fracture of the left lower ribs, elevation of the left side of diaphragm because of hemoperitoneum, and free fluid in the abdomen. Now next, this is an important sign, which is important test that is done in case of trauma of the abdomen. diagnostic peritoneal lavage. So what we do is we introduce a peritoneal catheter, lavage catheter, and through that we give normal saline is infused into the cavity. The patient is turned from right to left so that the fluid is infused. Now significant findings will only, it will be significant only when the aspirated contents show the following, that is 10 ml of gross blood or 1 lakh per cubic ml of RBC or more than 500 WBCs or bile, bacteria or food fibers or amylase more than 175. Why is amylase important here? Can somebody tell me? The tail of pancreas is injured along with the splenic hilum. Yes. Now, there is a splenic organ injury scale. This you have to, obviously this you have to learn up, but in basic this picture helps you understand. So it is a little complicated. What you have to understand is grade 1 is when there is less than 1 centimeter depth injury or less than 10% of the total surface area injury. There can be laceration or capsular tear and subcapsular hematoma, that is non-expanding. So non-expanding is till grade 2. Grade 2 is 1 to 3 centimeter, 10 to 50% of the surface area, and non-expanding subcapsular hematoma. From grade 3 onwards there is expanding subcapsular hematoma. That is the, because if there is a subcapsular hematoma and it is expanding, so it will cause pressure on the spleen and it will cause further tear of the spleen. So only grade 3 is important. In grade 3 there is more than 3 centimeter depth of laceration or rupture or more than less than equal to 5 centimeter and more than 50% of the surface area is involved. Let's come to grade 4. Grade 4 is there is devascularization of spleen because there is increased bleeding and splenic vessels are involved. There is devascularization of the spleen, but only up to 75%. Now why is grade 5 the most important surgically? Complete avulsion is in grade 5. Grade 5, there is the splenic hilum gets shattered and there is vascular injury. Now in grade 5 there is no role of waiting and watching. You have to directly go for intervention and you have to do splenectomy in grade 5. Let's come to the treatment. To any injury, you know that the first important step is ABCD, assessing the patient and understanding what should be your next step. So that is important. After that, you have to make sure in any ABCD, you know that you have to ensure that 2 wide bore cannulas are inserted. If central line is possible, that is very well. Apart from that, you have to go for urinary catheterization to look for output of the patient, and RT tube has to be inserted because of there is hemoperitoneum, there is irritation, the patient will go into ileus. So that is, it is better that you go for RT tube, and obviously the patient has to be admitted to ICU because regular monitoring with pulse and BP has to be seen. Shock, signs of shock, that is low BP, has to be monitored. Crystalloid infusion, that is RL for blood expansion. Obviously blood packet should be available. Antibiotic coverage should be given because the patient is in shock, and also to prevent further sepsis. Apart from that, fast CT scan, X-ray needs to be done, has been discussed before. Now let's come to non-operative management. A lot of times in splenic injury can be managed non-operatively also. Not every time you have to remove the spleen for preventing splenic further degradation of the patient. Obviously when facilities are available, in a tertiary hospital when there is ICU and everything, you can go for non-operative, but in a primary care it is not possible. Now it is used mainly for grade 1 and grade 2, also in certain grade 3 that shows hemodynamic stability. Now the key requirements for non-operative management is that the USG abdomen or CT scan can be regularly done. In case of falling hemoglobin in the 6-hourly hemoglobin, if the hemoglobin shows a falling trend, you need to go for a repeat CT scan to see whether there is further injury or not. And absolute bed rest should be there, suggested for the next 2 to 3 weeks with antibiotic coverage. Now bleeding points, this is an advanced thing. Angiographic selective embolization can be done, but it is available only in selected areas, not everywhere. Now when do you switch from non-operative management to surgery? Now if the patient shows hemodynamic instability, do not wait, go for surgical step, that is emergency splenectomy. Now risk factors in NOM will always be delayed splenic rupture. There is a expanding subcapsular hematoma and it leads to splenic rupture, or formation of splenic pseudoaneurysm that can further rupture leading to massive bleeding. Now surgical management is necessary whenever there is hemodynamic instability or there is associated other organ injury like colon or pancreas or kidney if there is any injury involved in these organs. Emergency splenectomy, this is about emergency splenectomy. Anytime you go on to the laparotomy, you should identify, before going on to the steps of the splenectomy, you should first identify if any other organs have been injured or not, to prevent bleeding first, then going on to the definitive surgery. Now, partial splenectomy can be done in cases of lesser grades when it is possible only the above or the lower spleen is removed after clipping the lower or the above polar branch of the artery. Now, splenography means just suturing the cut end of the spleen with after inserting a gel sponge into the cut part to ensure hemostasis. Now, splenic mesh wrap is not commonly done but can be done. A mesh is placed onto the spleen and is sutured so as to prevent it from getting ruptured further. Now, this is a rough understanding of how a splenectomy is done. First, you have to divide, this is actually a robotic splenectomy that is being shown over here. The operator first divides the gastrosplenic ligament and the short gastric vessel. After that, the splenorenal ligament is divided. Then the splenic vessels and the tail of the pancreas is made sure that it is separate from the spleen. After the spleen is separated, it is taken onto a sterile bag and through a morcellator. There is a device called as a morcellator. Yes, the spleen is broken out. This is a robotic approach, so it is a minimally invasive approach. So we take the bag out from a 10 mm port and through a morcellator, we morcellate the spleen into smaller chunks and we take out the chunk individually. Now, in short, I will be covering the indications for splenectomy. Basic indications is trauma. It can be either accidental or during an operation if there is any injury. Oncological, it is a part of the en bloc resection. If the spleen is associated with any other malignancy, spleen needs to be removed. Apart from that, diagnostic, it is not practiced these days. In earlier days, in case of lymphomas, the diagnosis for lymphoma used to be made after splenectomy. Also, it can be therapeutic. Hematological reasons being spherocytosis, ITP, hypersplenism. And portal hypertension, we go for variceal surgery. In case of shunt surgeries, we do a splenectomy in case of partial shunt or temporary or. Let's come to the complications of splenectomy. Hemorrhage, gastric dilatation, hematemesis, left-sided pleural effusion because it is in close contact with the left side of the pleura, and basal atelectasis, subphrenic abscess, pancreatitis due to damage of the tail of the pancreas. Also, it shows hematological changes after splenectomy, that is WBC and platelet count rises. Gastric fistulas are common if there is injury to the left side, greater curvature of the stomach. Infection. Now, let's come to infection. This is the most important aspect to cover in cases of splenectomy. Post-splenectomy patient shows overwhelming post-splenectomy infection, which is the most dangerous complication of splenectomy. Let's come to that complication now. So, basically, why does this happen? Spleen is responsible for immunity. A lot of immunity is being provided from the spleen. We remove the spleen. So, phagocytosis of encapsulated bacteria becomes defective. That leads to, so whenever spleen is removed, that phagocytosis bacteria opportunistically goes and infects the body, and the body is not prepared enough to tackle the encapsulated bacteria. So basically, the most common organism that is involved in OPSI is pneumococcal septicemia. That is, after that, other organisms can also be involved, that is Neisseria, Haemophilus influenza and Babesia microti. 4% incidence is seen after splenectomy. Now, the time frame and risk, the most common period for OPSI to occur is within first 2 to 3 years after surgery, but it can occur any time through the lifetime. So, the prophylaxis to prevent this is most important for such patients. Now, the risk factors for OPSI seen in certain patients are young age, thalassemia major, sickle cell anemia, lymphoma, immunosuppression. What are the clinical features that are seen in OPSI? Obviously, for any infection, there is a prodromal phase, that is fever, chills, sore throat will be seen. Apart from that, patient can show sign up till hypotension, shock and even disseminated intravascular coagulation. Respiratory distress can be seen, and obviously, if not treated promptly, it can lead to mortality. For a fully developed, why sore throat? Because pneumococcal pneumonia. Pneumococcus is more commonly seen in the throat, right? So, and obviously for a fully developed OPSI, the mortality rate is 50 to 70%, which is very high. Now, this is a very important topic, prevention of OPSI. So earlier, if you remember, for pneumococcus and all these things, initially it was that G penicillin was used, but the use of G penicillin has now been contradictory. Earlier it was like either 5 years or lifetime, right? But that is now contradictory. Now what they say is that antibiotics have to be given in case of infection. Apart from that, vaccine is very important in case of any splenectomy patient. So it depends upon patient's age and region. Now currently the standard vaccination includes your 13-valent pneumococcal conjugate vaccine, that is a PCV13 vaccine, which is followed by PPSV23, that is the 23-valent pneumococcal vaccine, and at least after 8 weeks, HIB, Haemophilus influenza type B, the meningococcal and the monovalent meningococcal serogroup B also has to be given. Also, yearly influenza vaccine has to be given to all such patients, measles, mumps, rubella, these vaccines, tetanus and dip to be given to such patients to prevent any kind of infection. Now these vaccines, the timing of these vaccines are of utmost importance, should be given 10 to 12 weeks prior to elective splenectomy. If a patient is undergoing emergency splenectomy, in such cases these vaccines have to be given immediately or 48 hours after surgery. But if the patient did not receive these vaccines before surgery, vaccine can be given up till 14 days after splenectomy also. Now treatment of OPSI. Now antibiotics that is most commonly used in practice these days is amikacin. But so that is what it is saying, that it can be given upon discharge or after 14 days, whichever comes earlier. So antibiotics commonly used is amikacin in practice. Apart from that, ceftazidime or cefoperazone can be used also. Ventilatory support and immunoglobulin transfusion can be done in case of severe cases, and TPN and maintaining urine output is important to look for signs of shock.